Good evening, everybody. It is Tara, and I'm coming to you live from the core up at La Encantada. If you are just joining us, you are most likely looking for our live stream lecture this evening with Dr. Koshkarian from Pima Heart on diabetes in the heart, sharing therapies. So before we get this talk started, there's a couple things that I just want to do to make sure we can maximize your experience for viewers that are watching online. Do know we have somebody here that is answering questions and making sure that we get those comments and suggestions to our speaker this evening. So if something comes up that you have a question about, don't hesitate to type it in. On Facebook, you can type it in on the comments. On YouTube, you can type it in, and we'll get those comments directly to our speaker before the end of the talk this evening. Of course, I encourage it. Sometimes a lot of those creative questions and that dialogue are what really take the lectures and the content to a different level, because if you have the question, then somebody else probably has it and maybe just hasn't asked. Other than that, if you do experience any audio or visual issues, send us a quick note, and if there's anything that we can do to troubleshoot, we will go ahead and do so. Before I hand things over this weekend, I'm ready for the weekend, tonight, there are some things coming up for the core next month that I want to make sure everybody's aware of. It is our 7th birthday, believe it or not. We have been here at La Encantada for 7 years. The next Black Friday, which is November, and oddly enough, the holidays are here. So keep an eye out for some celebratory events that we will be doing to celebrate 7 years of being out in our community. We'll have more on that in the coming weeks for you to sign up and hopefully participate in. So without further ado, I'm going to go ahead and mask up here, and I'm going to have Dr. Koshkarian come on up.
Thank you, Tara. And thank you all for joining. I'm happy to be speaking to you, and thank you for coming in person. I thought of this talk recently because we cardiologists are starting to think about using medications that have been developed for diabetes. And lots of questions come up from diabetes patients about things that are often used for the heart. And now us heart doctors are using things for diabetes, and I thought I would kind of combine them into one talk. One of the themes of this talk, and I'll get into this partway through, is the idea that medications we think of as sort of simple things that do one thing. They lower the sugar, or they lower blood pressure, or they lower cholesterol. But often these medications do other things that are not predicted by the way they were developed. And that is one of the things that's led to the concepts that we're going to talk about in this talk. So we will first be talking about cardiac medications that we use for diabetics, such as statins, antihypertensives, and aspirin, things that are traditionally in the cardiologist's armamentarium. And then the second part of the talk will be diabetes medications that may be beneficial for the heart. And you don't need to look at the details of all those abbreviations there, but these are 3 of the newest categories of medications that are used for diabetes. This slide was initiated by a discussion I had with some of my primary care physician colleagues, asking me, how do you get people with diabetes to want to take more medication that is, say, good for their heart? Diabetics are often on multiple medications anyway for their diabetes. And so I listed sort of the arguments why diabetics should be thinking about cardiovascular disease. First of all, it is the top cause of mortality. People with diabetes die of cardiovascular disease 2 out of 3 times. So while we think of diabetes as raising sugar and diabetic ketoacidosis and things related to sugar, cardiovascular disease is actually the thing that is the most serious threat to the life of diabetics. It doubles the risk of heart disease, and that's both myocardial infarction and congestive heart failure. It doubles the risk of stroke, which is something that most people fear more than just about anything else, including dying. And finally, it is a major risk factor for peripheral vascular disease, which may not end the life of people, but has a major impact on people's quality of life. It leads to claudication, which is the muscular cramping that occurs in the legs when the leg vessels are narrowed. Ulcers that occur in the foot or ankles often don't heal in diabetics due to poor blood flow from blocked arteries, and can eventually lead to amputation. So multiple reasons why people with diabetes should be thinking about cardiovascular disease. So this is a table that I pulled off the internet. It comes from the American Diabetes Association, and the question is, how do we decide which diabetic patients should be on a statin medication? And though there's a lot of details in this slide, and is this a pointer here?
Yeah, but it won't show on the screen.
Okay, all right. So much for that. Here's the thing I would point out, which is there is only one category where a person shouldn't be on a statin, and that is if you're under 40 and have no risk factors besides the diabetes. And the risk factors are listed off to the left there: an elevated LDL cholesterol, having high blood pressure, being a smoker, having a family history of early heart disease, chronic kidney disease, and albuminuria, which is, in a sense, a marker of kidney disease. So basically, everybody with diabetes, except for this small percentage of people, should be on a statin medication. And the variations are, should they be on high intensity, moderate intensity. My own philosophy tends to be, if you're going to take a medication, you may as well lower your risk as much as possible, as long as you're not having side effects. But the bottom line here is that most diabetics should be on a statin medication. When it comes to other treatments for diabetes, high blood pressure, the goal for diabetics is to have a blood pressure under 140 over 90. But consider more aggressive goals. Most people, most non-diabetics, actually, we now aim for less than 130 over 80. There are reasons we're not as aggressive with diabetics. Many diabetics already have established kidney disease, and the kidneys don't as much tolerate lower blood pressures. But it is certainly reasonable to aim for lower blood pressures in diabetic patients who don't have kidney problems. Aspirin should be used in patients who are at least 50 years of age and have another cardiac risk factor, like we showed in the previous slide, have a 10-year cardiovascular risk of 10%. And in various other parts of this talk, I refer to 10-year risks. We assess that with something called a Framingham score, which is based on an epidemiologic study that started in Massachusetts way back in 1948 and has been collecting data ever since then. And they found, actually, this is where the term risk factor came from. They found there were certain factors that increase the risk of heart disease. And nowadays, you can actually go online, you can type in either cardiovascular risk or Framingham risk, and there are ways you can plug in your own personal data and come up with what your own 10-year risk is. Consider aspirin also in younger patients if there are multiple risk factors. So the data on aspirin is not quite as clear-cut as it is for statins. There have been several trials, and so we don't have exact cutoff points, but these are reasonable guidelines for people with diabetes who should be on aspirin. All right, before we turn to diabetic medications in heart disease, I want to discuss the limitations of surrogate endpoints. Now, what do I mean by surrogate endpoints? When we treat people, we want to prevent bad things from happening. We want to prevent people from dying, from having strokes, from having heart attacks, from having congestive heart failure. Those are what we call hard endpoints. Those are the events of importance that we are aiming to decrease. Surrogate endpoints are factors that we think predict those harder endpoints. So for instance, high blood pressure tends to cause many of these things. Diabetes tends to cause many of these things. Diabetes is associated with increased sugar. So an increased sugar is in some ways a surrogate endpoint where people with high sugars also have these other bad things happen to them. But the problem with surrogate endpoints, if that's the only thing you're looking at a trial, is that sometimes what we see as association is not actually causality. And the point of this slide here with the umbrellas is, if you were visiting from another planet that didn't experience rain and you walked into an American city during a rainy time and you saw everybody with umbrellas, you might conclude that carrying an umbrella causes it to rain. There's an association between people carrying umbrellas and it raining outside. But as we know, the umbrellas are not what caused the rain. is the other way around. And that might seem self-evident to you, but I'll give you an example from my early training of what the danger of association and causality was. When I was in medical school in the 1980s, everybody who had a heart attack had 3 tests done in their follow-up period. They had some test of heart function, like an echocardiogram, because it was known that poor heart function predicted worse outcomes after a heart attack. Everybody had a stress test because ischemia, which is a sign of compromised blood flow, was associated with poor outcomes. And we did Holter monitors on people. So Holter monitors are monitors people wear for 24 hours, and they measure how many PVCs people have and other types of arrhythmias, because it was found that frequent PVCs was associated with an increased risk of adverse outcomes. Well, a few years later, when I was a resident, a very famous study called the CAST study was published, and it was a look at several medications that had been developed because they were very good at preventing PVCs. So prevent PVCs. PVCs are associated with increased risk of dying. Therefore, suppress the PVCs, prevent people from dying. But this study actually showed the opposite. The people got put on these drugs versus placebo actually died more frequently. And they died of sudden death. They actually died of arrhythmias. They also died of shock when they got septic, when they got an infection. And so this was really a landmark trial, not only for that specific topic, but it was really a trial that led to the era of large mega trials that are large enough to be able to detect whether these drugs affect things like heart attacks and dying, and not smaller trials that could only look at surrogate endpoints like number of PVCs. The trial also gets at the issue of off-target effects. So why did these drugs, which suppress PVCs, cause people after heart attacks to die? Well, as it turns out, while they were good at preventing PVCs, they caused another type of heart rhythm that was very dangerous. People with heart attacks have scars, and scars are a substrate for what we call reentrant arrhythmias. And these drugs actually made it more likely to have these kinds of reentrant ventricular tachycardia arrhythmias, and people would die suddenly from them. They also turn out to impact on the heart function and sort of decrease the heart's contractile ability. And so when people would get septic and have sort of a marginal blood pressure, these drugs would often tip them over into not being able to survive that. So that's the second aspect of being careful of surrogate endpoints, is beware of off-target effects. I'm going to pause here a moment because I just said a lot of sort of theoretical stuff, and thought I'll ask if anybody here has any questions, or if there are any questions that have already come in online. Okay, all right, so then we'll move on. So this gets now to diabetes medications. Can diabetes medications harm the heart? It turns out the answer is yes. 15, 20 years ago, category of medications that pioglitazone and rosiglitazone were discovered after they'd been marketed to increase the risk of congestive heart failure. Sulfonylureas, which were the mainstay and have been the mainstay, or had been the mainstay, I should say, of diabetes therapy for decades. I mean, they were the main things we used when I was in training. It turned out that many of them were associated with an increased risk of adverse cardiac outcomes. And finally, even some studies have shown that insulin can be associated with an increased risk of adverse cardiac outcomes. So again, this gets to the point of association is not causality. High sugars are associated with diabetes, and diabetes is associated with poor outcome, but that doesn't necessarily mean that lowering the sugar in and of itself will lower these bad events, because again, there are off-target effects that drugs may have that might negate the benefits they have in the way they work. Yes, sir.
I'm just curious about the trade names of some of these, because I recognize a couple of them as generic, but not necessarily what.
Oh, what you know them as. So, gosh, it's been so many years since the sulfonylureas have had brand names. I'm actually forgetting some of them, but I think Diabeta was one of them. But I do remember that pioglitazone, rosiglitazone were Actos and Avandia.
So these are older drugs.
These are older drugs. We don't use them you won't see people with diabetes on these nearly like you used to. What these kind of trials led to was in 2008, the FDA mandated that all new diabetes medications have large enough trials to make sure that they did not have adverse effects on the heart. I mean, if diabetics are dying of heart disease 2/3 of the time, then we have to be very certain that these drugs are not making that worse. All right, so there's a lot of sort of details on this. This is, for those of you who are interested, feel free to read the slide, but I'm going to summarize this rather more succinctly. So there's a category of medications called GLP-1 receptor agonists, and they're listed in the third bullet point there. But basically what they do is they act like a natural substance that the intestine releases when we eat. So when we eat, sugar levels go up. The sugar stimulates the release of these molecules called incretins, and they stimulate insulin release, which in turn makes the body pull the sugar into the cells and keeps the sugar from going too high in the bloodstream. So these drugs act like these endogenous substances that the body makes on its own, and therefore improves control of glucose. Another category, DPP-4 inhibitors, they block the metabolism of GLP-1, so they also raise GLP-1 levels, and similarly cause the release of insulin, and therefore improvement in sugar control. So two categories here that work kind of on similar mechanisms. A third category, the SGLT2 inhibitors, work on the kidney. So the kidneys filter lots of things, and then they reabsorb them. So they reabsorb things they want to reabsorb. And sugar is something they tend to reabsorb, and they reabsorb it along with sodium. So there's a channel that pulls sugar and salt back into the body, into the bloodstream, after it's been filtered in the kidney. And what these drugs do is they inhibit that channel, and therefore they lead to more sugar and more salt going out in the urine, and therefore less in the body. So they help diabetes control by getting rid of sugar, and potentially help heart failure by getting rid of excess salt. And we'll talk about that in a couple slides. And you can see the names of some of these: Jardiance, Farxiga, Invokana. So question is, what did these trials that were mandated to take place in after 2008, what did they show about these new categories of medications? Might DPP-4 inhibitors have cardiovascular benefits? Well, it turns out no. This category doesn't help the heart particularly. Several trials with these agents took place. A medication called saxagliptin had neutral effects on most cardiovascular endpoints, and actually had a 27% increase in heart failure hospitalizations. Similarly, alogliptin had a neutral effect and also led to an increase risk of new CHF that required hospitalization. Sitagliptin had a neutral effect on cardiovascular endpoints, including heart failure. So of the medications there, it looks like sitagliptin is probably the safest. It doesn't cause anything bad, but these drugs certainly shouldn't be used for the primary purpose of improving cardiovascular outcome. And for those of you now curious, so which of these is the safe one, the sitagliptin? Sitagliptin is Januvia. And interestingly, and although I don't prescribe these categories of medications, I hardly ever see my patients on any of the other DPP-4 inhibitors other than Januvia, and that's probably because it's the safest of that brand. I'm sorry, that category. Right. Turning now, sorry, having a little trouble here. Turning now to the GLP-1 agonists. Do they have cardiovascular benefits? And the answer is maybe they do. Semaglutide led to, in its trial, a 26% reduction in the primary endpoint of cardiovascular death, heart attack, or stroke. And throughout this slide, primary endpoints were always cardiovascular death, heart attack, or stroke. There was no effect on the individual endpoint of cardiovascular death or total mortality or heart failure hospitalizations. So most of the benefit was driven by a decrease in heart attacks and strokes. Liraglutide had a 13% reduction in the primary endpoint, but it had an even more pronounced effect on cardiovascular death of 22% and a 15% reduction in total mortality. So that was an impressive finding for a diabetes drug. And by the way, as I indicated in an earlier slide, most diabetes drugs don't improve cardiovascular outcomes. In fact, most of them have been shown to be some risk. Before these trials came out, the only drug that looked like it was potentially beneficial is metformin. And that's why metformin is now first-line treatment for all diabetics before anything else. But now these drugs are showing that they potentially have benefit also. Lixisenatide had a neutral effect, same with exenatide, but a drug called dulaglutide had a 12% reduction in the primary endpoint, but no effect on total mortality or heart failure hospitalization. So in summary, some of these drugs have benefits, some don't have benefits. And so we can't say there's what we call a class effect. Class effect means you can pretty reliably feel that anything in its class will do the same thing of anything else in the class. Some of these drugs benefit, some of these don't. So we want to use the specific drugs that have been beneficial. And in case you're curious about their brand names, I'll go back. And the semaglutide is, where is that? Ozempic or Rybelsus. Liraglutide is Victoza. And dulaglutide or dulaglutide is Trulicity. All right, so now we're going to turn to the most impressive findings, the SGLT2 inhibitors. Do they have cardiovascular benefits? So empagliflozin, which is Jardiance, these ones I have memorized because I'm starting to use these drugs now, improved the primary endpoint of cardiovascular death, heart attack, stroke by 14%. Cardiovascular death by itself was reduced by 38%, and total mortality by 32%. And there was a 35% reduction in heart failure hospitalizations. Now realize, all these trials I'm talking about right now are people with diabetes, may or may not have heart problems, and these trials are looking to see what happens to these people over time. Canagliflozin, which is Invokana, reduced the primary endpoint by 14% and had a 33% reduction in heart failure hospitalizations, but it had an increased risk of amputations. So we will not be seeing a further trial of this drug in the heart setting. But dapagliflozin, which is Farxiga, had a neutral effect on the primary endpoint, but a 27% reduction in heart failure hospitalization. So as you can see, there's a trend here that all these drugs are reducing hospitalizations for heart failure. And this was a surprising finding. This was as surprising as the reverse of what they found 15 years earlier with Actos and Avandia, where people were having more heart failure. And again, it gets to the point that though all these drugs are lowering glucose, sugar, they have other effects that aren't necessarily predictable by what they do primarily in terms of the sugar. And these drugs appear to reduce the risk of heart failure. So based on this trial in 100% diabetic population, 2 of these drugs went on to do some studies looking at patients who didn't necessarily have diabetes, but did have congestive heart failure. So all these patients had New York Heart Association class 2, 3, or 4 heart failure. And we have classes 1 through 4, which kind of rate how symptomatic a person is. Class 1 is an asymptomatic person. So all this means is these were people with symptomatic heart failure. And in the first trial, called Emperor Reduced, these were heart failure patients who had reduced ejection fraction. So ejection fraction is a measure of heart function. So these are people whose ejection fractions were 40% or less. And the primary endpoint in this primary outcome of this trial was cardiovascular death or CHF hospitalizations. And in fact, that was the endpoint in all of these trials. It was reduced by 25%, and heart failure hospitalizations in particular were reduced by 30%. So empagliflozin or Jardiance did a similar trial, but looked at patients who had better heart function. So heart failure with preserved ejection fraction. All these people had ejection fractions over 40%. So that include people with mildly reduced ejection fraction, because a normal ejection fraction is 55% or more. So it was either mildly reduced or normal. And they reduced the primary outcome by 21%. Heart failure hospitalizations reduced by 29%. And finally, dapagliflozin, or Farxiga, it reduced the primary endpoint by 26%, and worsening heart failure by 30%. And it had a trend for reducing cardiovascular death by 18% and total mortality by 17%. So very impressive findings for these drugs.
Are all different kinds of diabetes, all different types? It didn't matter what type you were.
So this was predominantly people with type 2 diabetes, but I don't believe they excluded people with type 1 diabetes. But in this category of this age category and people with heart failure, it's just much more common for it to be type 2 diabetes. So how do these drugs work? Well, there are several mechanisms that have been looked at that don't appear to explain how they are reducing heart failure so much. So yes, they control sugar, but as we said earlier, other drugs that lower sugar levels don't have the same impact. And these drugs actually are not among the most potent at lowering hemoglobin A1C, which, as some people know, that's a measure of your average sugar over the past 3 months. So it's kind of a way of looking at the general control of diabetes. The benefit doesn't appear to be related to that. These drugs do cause some weight loss, but it's very minimal and not enough to explain heart failure reduction. It does cause diuresis and natriuresis, so loss of water, loss of salt in the urine. But diuretics in general can't be said to have this kind of a benefit. In fact, the most potent diuretics, the so-called loop diuretics, the most familiar for most people is Lasix, has not ever been shown to have any major impact on cardiovascular outcomes. They lower the blood pressure a little bit, but again, fairly minimal, not enough to explain these benefits. So once again, this gets back to off-target effects. So off-target effects can be bad, but they can actually be good. An example of that is statin medications. So statin medications we take and we think of as lowering cholesterol, but it turns out they also have anti-inflammatory properties, and some of its benefits are from that. These drugs, these SGLT2 inhibitors, have off-target effects also that may explain some of their benefits. And I'm not going to go into any great detail here, but they may favorably influence energy utilization. They have anti-inflammatory properties. They may inhibit the sympathetic nervous system, which is activated in heart failure and is not good for the heart. They may improve vascular function, and they may decrease oxidative stress. So nobody's proven exactly which of these is the most important. It may be that somebody got lucky enough to develop a drug that has a little bit of effect on all these systems, and it adds up to a major benefit. But again, it's one of the reasons why it's really important to do trials that look at these hard endpoints of dying, heart failure, heart attacks, things like that, before deciding something is safe or beneficial for the heart or anything else. And parenthetically, I'll mention it's one of the reasons why we doctors are not so gung-ho about over-the-counter remedies. It's not that they're inherently not good for you, it's that they have not been tested in these large trials. And something that is labeled an antioxidant might have other effects that have an adverse outcome that we just don't know about. So how do SGLT2 inhibitors stack up against standard of care? So what is the standard of care for the average heart failure patient who has reduced heart function? It's a beta blocker, a medication that is one of 3 categories: ACE inhibitor, ARB, or what is now called an ARNI. Entresto is the only drug in that category. And the third category is the aldosterone antagonist, and represented here by spironolactone. So I just showed a smattering of some of the major trials of these drugs to see how it compares with the SGLT2 inhibitors. So when you look at heart failure hospitalizations, these drugs lower heart failure hospitalizations as well, if not better, than many of the other drugs in these categories. When it comes to cardiovascular death, there may be a benefit. Talked about dapagliflozin lowering that by 18%, and that compares pretty well with candesartan and Entresto. Total mortality, there was a trend with that drug of 17%, which again compares favorably with the candesartan and Entresto. Nowhere near as good as what carvedilol achieved 20-something years ago in their large trial, and not quite as good as what spironolactone does. They also have benefits in patients with preserved heart function. So heart failure, and this is a simplistic way of putting it, but we think of heart failure with either reduced heart function or with relatively preserved heart function. And most of these drugs have only been tested in people with reduced heart function. Well, at least empagliflozin or Jardiance has been shown to be beneficial if you have normal heart function with your heart failure. Carvedilol, we don't really have data on. Candesartan was tested. It did not show a benefit. Entresto has shown a benefit. And spironolactone, their data was somewhat equivocal. So overall, SGLT2 inhibitors seem to compare very well. And in fact, very recently, it led to a change in the ACC guidelines of how to treat heart failure. ACC is the American College of Cardiology. They parse the data. They come up with guidelines that help guide those of us in the trenches of practice. And what we used to think of as triple therapy is now being thought of as quadruple therapy, where SGLT2 inhibitors are now kind of a standard therapy for this group of people. And we're starting to add this. And that's, as I said, where I have started actually prescribing these medications that just a year or two ago I would have thought of as diabetes medications. I'll leave that to the primary care physician or the endocrinologist, but now I've been prescribing these. So in summary, diabetics should be taking statin medications for the most part. Individualized blood pressure control, definitely under 140/90, but consider lower targets. Consider aspirin, depending on other factors with the diabetes. SGLT2 inhibitors appear to be beneficial for heart failure. And stay tuned, there may be more data coming out in the future for GLP-1 agonists in patients with coronary artery disease. So that's it.
Any questions, anything?
I'm taking Ozempic. I've been on it for 6 weeks.
For, I'm sorry?
Ozempic.
Yeah, for, but you said, okay.
So for diabetes and heart issues.
And is Ozempic semaglutide?
That's the one, yeah.
The first one that was
The
discussed?
second one, it's the it's a GLP.
Yeah, yeah.
Does one have to stay on that? Or is that a temporary?
Well, it all depends on why a person has diabetes. So you do not look like a particularly overweight person. I have seen people who say have bariatric surgery who lose 100 pounds and they stop having diabetes. And so they come off of their medicines. Most people with diabetes, though, can't stop their medications. The diabetes doesn't go away. So it's not that you get addicted to the medication. It's just that the reason you're on it doesn't go away. It's similar for high blood pressure. High blood pressure isn't something we cure. We put people on medication to control the blood pressure. So
I've lost 30 pounds, 22 pounds.
Yeah, and so what I would suggest is, talk to your primary care physician or your endocrinologist, see where your hemoglobin A1C is running, and is it possible that you could have a trial off of that.
It's not particularly pleasant.
Well, it's an injection, right?
Yes.
Yeah. Is it daily or once a week?
It's once a week, and you have to start off at 0.25 milligrams. You go through like 2.
Mm-hmm.
Okay. And along with that is a low carb diet
Sure.
and vegetarian. So it's a real challenge.
Sure, I understand. Well, good luck with that conversation. Any other questions? Okay,
Thank you so much.
sure thing. All right,
Thank
thanks for
you.
coming out. Thank you.